Ali Khan. I am a general internist and regional medical officer for Northern California and the Bay Area, back west in San Francisco, and just heading out from 3 years at IR Health as their director of physician engagement.
Morning, guys. So I'm a big believer in waking up in long meetings like this because we sit forever and we're always here. So I'm just going to ask you guys a couple questions and just stand up if it resonates at all. So how many of us here in the past year or so have woken up at 2 o'clock in the morning frantic with worry that our patient didn't fill that prescription that we know is super critical? Some raised hands. Let's stand up. Stand up. We got some. I know some people are not doing as much clinical anymore, but you know this experience. All right. How many of us are sitting here in this conference, right? Like scheming workarounds on how to fit trust-replete cultures or parsimonious measurement or any of these ideas that are swirling into our already packed professional lives? All right, see, brutal honesty, always good. And how many of us, at some point or another, have just looked inside and felt like we're worrying alone? We got a couple. Not a lot of worrying, I see. All right. The worrying alone. Totally alone. Okay. But so, right, that's how we do, right? Like that's why we went into primary care. We have overcome so many different social, economic, cultural disincentives to enter this field, right? And so to survive, we've kind of wrapped ourselves up in this mythology of the unsung hero, right? The person who sees 22 patients a day and is writing notes till 11 o'clock at night. And the reason for that is because we squeezed in 2 urgent visits and we ran a fundraiser for our patient who can't afford his biologic to control his severe autoimmune disease. And I spent my lunch hour knitting a sweater for another homeless patient. And, right, like, why do we do this? Because we care, right? That's what we're here for. But it's also because we are primary care martyrs, right? We think that we are these, incredible people who were super collaborative and we're ready for teams and we trust nurses and we love population health and we're doing all of this. But we're actually lying to ourselves, right? In the sense that we don't actually know what teams mean. And we don't have the trust in them to actually be willing to cede control. We don't actually believe in shared ownership either, right? Because we don't know what that is. We were taught that we're supposed to do it all, right? This is what our prevailing mythology compels us to do. And so we're stuck, right? And so the issue here then is that if we're going to move forward, if we have to divorce ourselves from this mythology, right? Our emphasis in primary care on risk aversion, on risk prevention, right, which is what we do in clinical care and systems all the time, is what's holding us back. So in the same way as Aaron said, if we're actually going to move forward on making primary care teams real, but also if we're just going to move forward on the idea that we're actually going to impact people's lives in ways that really matter, then we need a different rallying cry, right? We have to let this mythology go. And so that rallying cry from our evidence and our work over the past decade in looking at teams is really this. Shared ownership leads to agency. So step 1 is admitting that I can't be a martyr anymore. That I have to rely on other people, maybe a bunch of people, that shares the burden of responsibility with me for taking care of these people, taking care of this population. That's shared ownership, right? That's learning to let go. And then step 2 is saying, how do I actually build the environment necessary to cultivate that real shared ownership, and then sort of watch what emerges. And that's agency. And so how I've seen this done in our work over the past decade sort of is interesting. And it's hard because we have a tendency to frame agency as dangerous when it's people who aren't us. We worry about licensure, we worry about scope of practice, we worry about training, we worry about whether we can trust people to follow through if they don't have our training and expertise. But this is the wrong mental model, right? The issue that emerges then is that we have to learn how to, take meaningful action and learning to let go around those teams. And over, my colleagues and I in the room, you know who you are, have spent inordinate amounts of time thinking about how teams work with real impact, whether that's in community organizing and political advocacy, or ward teams, or corporate management, or looking even at human rights work. And from all these arenas, one kind of common truth emerges. Teams of impact share a common mission, and they have the collective will to operationalize that mission. And I've spent the past 5 years immersed in that philosophy at places like IORA, like CareMore Health Systems, and at the early days of the VA Patient Line Care Teams initiative. And there are complementary and differing lessons from all those places. But the central truth that emerges is this. Great IT structures and payment reform are great, but the crux of what matters in this arena is that philosophy and that tendency of doing everything possible to do the right thing, to earn people's trust. And we've heard about trust a little bit, obviously, from Aaron, and we've heard a lot of stories over the years about how these frontier models, or just how everyone is doing great things to build trust between patients and a care team. But we're only now just starting to unpack what it means to build trust within the team itself. And so, in that regard, how have these vanguard models, sort of the ones that are off-cited and the ones that are a little bit more obscure, earned that trust? They've done it through operationalizing agency, through a culture of deliberate, intentional shared ownership, and their outcomes really bear that out. And the model there that exists is one that is hard to do, right? Well, I'll tell you from the trenches at IORA and the trenches at CareMore, it takes time to build trust, right? This doesn't happen immediately. As much as we want it to, we can build a team and say, go forth, but it doesn't necessarily work like that. But what it requires is really kind of real naked vulnerability. So for us as providers, it's the vulnerability to let go amid fear, to silence the voice in my head that says, well, I want to be the person who's doing nutrition counseling, and then I want to take my 6 diabetic patients to the supermarket and teach them which tortillas to buy, because that's why I went into primary care, right? And instead realize that if I'm going to affect the change that I wish to see in the world, then I have to learn how to depend on others. And on the other side, for our team members, for our MAs, our health coaches, our community health workers, our non-physician providers, our behavioral health specialists, our social workers, they're facing the vulnerability to step up amid fear, right? The fear of deviating from a defined protocol and what might happen, the fear of messing up, the fear of doing something wrong and the consequences that result, right? So together for the team then, it's actually about owning collective vulnerability, about acknowledging and recognizing that fear, that worry, and then owning it as a part of building this darn thing, right? Of building the team before us. And that, can be challenging, but it's necessary, right? Because trust doesn't just blossom automatically. It blossoms through real meaningful intentionality. At IORA, for example, and at CareMore, daily hour-long huddles where the whole team is talking about patients who we think are in crisis, right? Literally going over a worry list for the practice. And reinforces that everyone can, these problems belong to everyone, and that anyone can contribute to a solution, right? It also is somewhat of a forcing function in that, and this has happened to me over and over again, where I'm able to admit I have no idea what to do with our patient who's been readmitted 5 times in the past 6 weeks for advanced complications of sickle cell disease. But it offers then a learning opportunity for the collective to learn and change and grow together. And what it also does is happens in the little things. Rotating leadership of who runs a huddle on a daily basis, from everyone from an operations assistant all the way to a medical director, actually reinforces that we all run this practice and that these problems are ours and are owned by all of us, but that a solution can emerge from any of us. So in that context, at the vanguard, this kind of shared ownership is given much more than lip service. It's real, it's intentional, and the trust that emerges is no accident because it's fed by, and then it reinforces that shared ownership and agency. And that's what shared ownership can do, right? So shared ownership enables a layperson community health worker to take a phone call from a patient at 2 a.m. and lead her through breathing exercises and meditation for 45 minutes that actually prevents her from going to the ER that night when she's gone 4 times in the past 3 weeks for anxiety with a little bit of chest pain. It unlocks the social worker's great idea for a patient of ours with known complications of diabetes who's getting evicted from his house that tends to have problems with his insulin dosing, that in order to make sure that he doesn't go into diabetic ketoacidosis, we're going to go pack his boxes. And we're going to label it really clearly which one is insulin so he doesn't forget. And what it does for the physician is that it enables them to take the crazy idea of buying air conditioners for our elderly patients in the middle of an unseasonable heat wave in Arizona and makes it possible to do that with secure in the knowledge that his team, including a health plan administrator, is not only condoning that work, but believes in it. So, to that point, this is the context in which we hope this emerges. And that shared ownership emerges in those huddles and then is reinforced through this, dense interactions and spontaneous collisions that happen in a co-located working space, like we see at IORA, we see at the South Central Foundation, where you're sharing patient stories, but you're also watching stupid YouTube videos, and there's spontaneous potlucks that are happening because somebody brought in chips and somebody else brought in some weird salsa. And that leads to joy. That ownership is then reinforced through the protected, regular communication and the structured mechanisms for input that generates the buy-in from a team. And then it's enriched by by operationalizing this actual work through role definition, through coaching, through training, through things like standing protocols and population health management and in systems work that actually gives our team agency. So, and in this work, it's not just IORA that thinks this, it's not just CareMore that thinks this. When we look at so many examples of the vanguard now, ChenMed in Florida, the South Central Foundation in Alaska, the University of Chicago Comprehensive Care Project, Oak Street Health in Chicago, we see that these organizations are meaningfully trying to move towards an intentional culture of agency through that intentional design and execution. And for the skeptics in the room, I'll admit, if it's all protocols and care design and care delivery pathways, there are a lot of organizations out there, we won't name them, who are doing really great, who've done great work in this field. So shouldn't that also just lead to agency? But here's the rub. Having spent time in some of those organizations, including 4 nights ago, I can tell you that that's not the case, because you can't protocolize trust. The kind of culture in which a health coach or an operations assistant with no medical training can hear a story about a patient who keeps getting admitted after dialysis sessions for complications of volume overload because he goes to dialysis, gets nervous because he can't listen to music, and then decides to rip out his dialysis catheter and leave. For that coach or that operations assistant to be able to say, why don't we just buy the guy an iPod and load it with music that he can listen to during dialysis? And for that idea to be trusted and taken seriously without needing a physician or non-physician provider's check mark or stamp of approval doesn't come from a protocol or just role definition alone. It comes from a real sense that this team owns problems together. So in this sense, we have from lessons from the Vanguard in terms of building the kind of culture that enables ownership and shared agency. And it's unfortunate that these organizations have had to do this and go outside of the payment reform systems that we currently have, right? They've done this outside of fee-for-service. But they've done that not so much because they're looking to do this to be iconoclastic, but because they say this is how we get to the place to unlock the creativity, to accommodate the vulnerability necessary to get teams to actually be able to do the right thing. And that is, a lesson that is incredibly reinforcing when you think about the context, and as my colleagues and I have studied and observed these teams and lived in these teams, at these places, nobody is worrying alone. And that is incredibly freeing as a physician. And so, not everyone can make this leap. And not everyone can do this, but we have examples. There's a great paper from Annals in Family Medicine from last year talking about dense interactions, looking at the density of interactions among primary care teams and their effect on cardiovascular outcomes in the primary care setting, in cost and quality. And teams with dense interactions actually saw fewer hospital visits and cost savings per person of over $500 per year. Not so dense interactions, lower social capital, exactly the opposite. So even in a world where there wasn't payment reform, where we didn't have this ideal system, IORA sitting in Vegas, it can be done if you have the will to build that shared trust, to build that shared agency, to get to real ownership. And so how we get there then is sort of through three pieces. It's through that intentional design of the structure, it's through the operationalization, that implementation, and it's through measurement. From the structural design, it's building the physical plants and the communication structures to allow that team to live and grow, to feed those dense interactions. On the implementation side, it's taking the things that we've learned from people like Nwando and UCSF and people like Krasinski and all over the country and saying, this is how we operationalize agency through protocols, through role definition, through coaching, through professional development, through population health management. And it's the measurement of saying, how do we measure agency? Whether it's through inventories like the Maslow burnout inventory or net promoter scores or UCSF's doability question. But that we track it and it matters to us in terms of how we affect a team hygiene. So this is the challenge before us. We may not get as far as we want to get without payment reform, and that's a whole other talk. But payment is not enough alone. To get where we want to go, we can let go of this trope of the primary care martyr and actually learn to help lead teams of impact. We have the blueprint before us. You're literally in this room over the past few days surrounded by architects of the Vanguard, right? And so we can get there. We can take this opportunity right now in this room to look inside ourselves, see what bright spots emerge to take to scale, and build that blueprint right here, right now. And at least my motive for that is that agency leads to trust, as I've discussed and Aaron's discussed, but agency also leads to joy. I've seen it, I've felt it, I've lived it, and I've loved it. And I can't go back to being the primary care martyr. And after 2 days of debating and arguing and listening and laughing with all of you, I suspect that all of y'all feel the same way. So let's go have some fun.